Good afternoon, everybody. السلام عليكم ورحمة الله تعالى وبركاته. جمعة مباركة على الجميع. أهلا وسهلا بضيوفنا الكرام. I would like to welcome everybody in the master class of IBD of 2024 of the Saudi Gastroenterology Association. My name is Yusuf Gari. I'm a consultant gastroenterologist from King Abdulaziz University Hospital. And we would like to start, if we can call the attendees outside, if somebody can call them. We want to kick off on time. So this is the first session, and our first speaker is Professor Gareth Parks, who is a consultant gastroenterologist at the Royal London Hospital, London Clinical Director of Ampersand Health. Professor Parks is a consultant gastroenterologist who graduated from the University of London in year 2000 and specialized in gastroenterology. He has been involved in research in a number of areas, including Crohn's disease and the effect of smoking on inflammatory bowel disease and the use of probiotics and prebiotics. His main area of interest is in IBD, and he is going to talk to us about positioning advanced therapy in Crohn's disease. Professor Parks, welcome. The floor is yours.
Thank you very much. Well, thank you, and a huge thank you to both the chairs and to the organizing committee of this event for asking me to be here. It is an honor and a pleasure to be here. I think my slides are up. They're not showing here on this screen. So today, this morning, we're going to open this session with an increasingly difficult job, which is how we might position and layer and think about all the new drugs that we have in our armamentarium to treat inflammatory bowel disease. And I'm going to specifically concentrate on Crohn's. These are my disclosures. And when I think, and I sit with a patient, I saw 2 new patients yesterday, I break it down into a couple of simple steps. Where am I going to start? What are my goals for treatment? And we're going to hear more on that later on with things like STRIDE. What tools have I got that might allow me to know and compare between different agents? So we can look at a few of them, network meta-analysis, head-to-head studies, but really what I want is a smart tool that allows me to take a simple blood or stool test from a patient sat in front of me and to know from that test exactly which drug is likely to be the most effective agent for that patient. And we're beginning to see a bit of that come through in biomarker strategies, but we're some way off that. Then I'm going to sort of controversially suggest that maybe it's not which drug you give, but it's how fast you give it and when you give it that matters and makes more of a difference. And then some very much my own opinions on what we are doing now in London with some of the constraints that we have on our practical steps for you in a clinic, and then bring it all together. So where do I start when I'm thinking about a patient? So what are the goals of my treatment? Am I going for mucosal healing? Am I just trying to get disease control? Is it about symptoms? Really importantly, what are my patient's goals? Because often we know that they're quite different from the goals that I might have. They might be preoccupied in safety in a way that I'm perhaps not. Where is the disease? What are their comorbidities? And that's not just, we need to think more and more about the things like cardiovascular risk, cancer risk, moving forward, but also what are their extraintestinal manifestations? Can I use an agent that might treat both of those things? Are there cost constraints? Oh, this would be tremendous if that could come up. So are there cost constraints that, without the slides, it's going to be quite tricky. I'm good, but I'm not that good. Okay. 1 minute. We'll do a take two. Aha, fantastic. I'm still not on here, but anyway. And then I like to think of IBD now as a bit like a chess game. You want to think about both your first move, but you also want to think about your second and maybe even your third move, so that when you're starting an agent, some of them aren't going to work, and you need to know what your second agent is. Have you prepared the patient for that as well? So always try and think a couple of moves ahead. Okay, so the landscape has certainly got better. I first started training in gastroenterology in 2004 when we had one licensed agent as an advanced agent in inflammatory bowel disease. And obviously that picture has moved on enormously. And coming forward in the next year, we should see more agents, although they're going to be in similar sort of areas. We hope that etrasimod might succeed where ozanimod hasn't. And more interestingly, the pipeline, so I'm really interested in clinical trials, and I've chosen these three completely at random. The pipeline is not only interesting, but it's got some really novel mechanisms of action. So we're going to start seeing new agents come, we hope, through the phase 2 and 3 programs that might offer even more choice for our patients. And there are many more of these coming. So there's a huge amount of investment in Crohn's and in inflammatory bowel disease, which is fantastic to see. So really, we want a crystal ball. We want to be able to know, with that patient sitting in front of us today, which of all these agents is going to be the most effective agent for that. But that's tricky. So maybe we'll think about goals instead. Well, the goals, in many ways, we're going to talk about in later talks, but we're not just content with symptomatic improvement. We need to treat patients early. We need to treat them with effective treatments early and prevent complications happening. I think all too often in Crohn's, you feel like you're chasing. You're never on top of the disease. And in some patients, the disease is always 2 steps ahead of you. They've penetrated. You fail to get their inflammation under control. And we've got multiple studies showing the benefits of that. And of course, we're going to hear more about STRIDE 2, which is neatly set out for those who haven't seen this. Perhaps you specialize more in endoscopy. But STRIDE 2 says you should break things down into 3 easy steps. A short-term goal, getting a patient feeling better, so a good induction agent that will get them feeling better quickly. And then second thing would be biochemical control, so that's reductions in calprotectin and CRP. And then the third is mucosal healing and preventing disability later on. So that would be endoscopic control. But patients have different ideas, and this is just a sort of sample of the kinds of things that they might be worried about. And in there, perhaps our patient is more worried about a drug that's efficacious, but also safe. Many of our patients, their goal is to come off all treatment. And in Crohn's disease, we might have to break it to them that that's increasingly unlikely to be able to happen. They want it to be convenient, and they want durable agents as well. So we can use tools to try and compare all these new drugs. And the tool that we've seen over the last few years is network meta-analysis. And this works by anchoring all these different trials where we don't have head-to-head studies back to placebo. All of our trials at the moment in inflammatory bowel disease all have to have placebo as part of phase 2 and phase 3. So we can compare different drugs and how they do above placebo in order to give us an idea of which might be the most efficacious. But we've got to be careful with this because all these trials were done at very different times over the last 25 years. So more recent studies include patients who are refractory to multiple drugs, and that's very different from, say, the original Accent trial where all patients were naive by definition, and they had different endpoints. So the Gemini studies where they used a week 6 endpoint, increasingly now we're only seeing week 12. So we do need to be a bit careful. But that to one side, these are the kind of results. Now, they're not the most beautiful way of trying to represent data, but if you look at the top left, that's a forest plot to try and achieve remission in all comers. So that's when you pull all the patients together, both those that are bio-naive and bio-exposed, and which drug is the most effective. And unsurprisingly, infliximab comes out top because the infliximab studies were all done in naive patients by definition. When you look on B, you look at those patients who are bio-naive. So when you sub-look into plots, and unfortunately, upadacitinib drops out of this analysis, but you can see, because this one's a little bit old, but you can see there that risankizumab for a bio-naive patient appears to do the best, and also for those who've been bio-exposed below. When it comes to the maintenance therapy, it's a bit more difficult to use network meta-analysis, and this is all to do with the